We'll just give a few minutes for more people to join. I think we can start. The number of participants has stopped growing for now. So good evening, everybody. Thank you for joining to our webinar organized with the Society for the Study of Celiac Disease about the highlights from the International Celiac Disease Symposium that happened in Sheffield in September this year. The webinar committee is formed by Sharon Weston, Vahe Badalia, Andrew Ford, Catherine de Geeter, and myself. And we will present a few abstracts that caught our eyes. There were so many abstracts, so many great presentations. So it was really hard to pick. Sharon will talk to you about the dietitian abstract, the nutritional abstract. Catherine will talk to you about the pediatric ones. Drew about a software that assess the villus atrophy, and I will touch upon a few subjects regarding refractory celiac disease. And we could have some discussion after each section of the presentations if the audience wants to raise some points or some questions. Yes, so Sharon, if you want to start.
Okay, great. Thank you. So I'm going to be presenting on the dietitian and nutrition abstracts that were presented on day 2 of ICDS in the Satellite Symposium. And I have to say that the session was very well attended, and they actually needed a bigger room. So the first abstract that I'd like to present was done by Drs. Govind Makaria and Wajia Mehtab from New Delhi, India. And they investigated current practices, attitudes, and knowledge of Indian dietitians towards celiac disease and a gluten-free diet. And just to give some background information, they provided that had to do with a previous study that they had shared that looked at 970 patients that had celiac disease in India, and 91% of those patients were counseled by a physician, but only 61% were referred to a dietitian. And they also found some data from the US that also indicated that only about 50% of patients are referred to a registered dietitian. And so just looking at their methods and results, so they use a web-based questionnaire that was developed based on group discussions and expert group meetings to assess the knowledge and attitudes and practices of dietitians towards celiac disease and a gluten-free diet. And the questionnaire was administered to the members of the Indian Dietetic Association through emails and also using the WhatsApp social media platform. And this comprised about 7,670 members. And what they found was overall 551 dietitians responded to the survey. The response rate was about 7%. A total of about 64% of the dietitians were practicing counseling for a gluten-free diet, of which about 69% were seeing 1 to 5 patients per month. In the knowledge section, almost 60% of the dietitians lacked the basic knowledge of celiac disease. So for example, 27% didn't know that a gluten-free diet is the only definitive treatment for celiac disease. About 40% of the dietitians had wrong beliefs for celiac disease. So for example, about 24% agreed that a gluten-free diet can be stopped after disease remission. About 29% agreed that patients with celiac disease can occasionally eat small amounts of gluten. And among the practices, about only 25% of the dietitians spent more than 30 minutes for dietary counseling. 75% were regularly monitoring the growth parameters for children and adolescents. About 70% provided label reading tips for packaged food, and a large number did not follow any definite protocol for recounseling after the first counseling session. And so in conclusion, they stated that current knowledge, beliefs, and practices of Indian dietitians towards celiac disease and gluten-free diet is suboptimal, and hence evidence-based guidelines and continued structured education programs are needed for dietitians in the specialized area of celiac disease. The next abstract that I'd like to present was done by Vanessa Weisbrod and was titled Culinary Medicine Program Improves Health Provider Confidence in Counseling Patients with Celiac Disease. And this pilot program investigated the impact that the first 2 culinary medicine webinars from a planned series had on attendees. 1,248 attendees viewed the first 2 webinars live. This included healthcare providers and also patient families. And also as of July 11th, over 10,000 views were done watching the recording. 343 healthcare providers also claimed credits for the first 2 webinars. And what they found was that the high level participation and positive feedback from both providers and patients underscore the effectiveness of this approach of using culinary medicine webinars in enhancing understanding and confidence in managing celiac disease and a gluten-free diet. Vanessa also presented a second abstract that touched upon really the practical aspects to mitigate the risk of gluten cross-contact in shared kitchen spaces and sought to expand upon existing data. And so the methods that they used were 4 different experiments. The first one looked at the level of gluten that was measured on gluten-free bread that was toasted in a shared toaster oven or a pop-up toaster. Both frozen and shelf-stable gluten-free breads were used. The second experiment measured gluten on gluten-free pasta that was cooked in pots that were previously used to cook gluten-containing pasta and then washed, and both stainless steel and nonstick pots were tested. The third experiment measured gluten on gluten-free pasta that was strained in a colander that was previously used to strain gluten-containing pasta and then washed, and plastic, metal, and silicone colanders were tested. And then the fourth experiment measured gluten on gluten-free bread after being sliced on cutting boards that were previously used to slice gluten-containing bread and then washed. And the washing was standardized for all of the experiments to use hot soapy water while singing happy birthday. And all gluten measurements were made using the Biofarm R5 ELISA sandwich assay. And the results showed that every sample in the experiments for 1 to 4 tested less than 5 parts per million. And really they pointed out also just that the amount of gluten transferred from the shared toaster is negligible and can be considered a low risk. The next abstract that I would like to present was done by Sonia Meyer and Ora Friedman, Jess Lebovitz, and Ann Lee on the topic of navigating the social landscape, the influence of celiac disease on dating behaviors and social anxiety. And their objectives were to first validate the cultural applicability of a US developed questionnaire in Israel, which was designed to examine various dating behaviors among adults with celiac disease. And then they applied that questionnaire to adult patients with celiac disease in Israel. And adults with celiac disease were invited to participate in an anonymous online survey through social media groups for celiac disease. And 199 participants completed the survey. Measures included a demographic questionnaire, a celiac disease specific and dating oriented multiple choice questionnaire, celiac disease quality of life questionnaire, social anxiety questionnaire, and celiac disease food attitudes and behavior scales. And the results indicated, first, most of the dating with celiac disease participants reported that they were not currently in a relationship. About half of the participants reported that they have an online profile, but only a fifth mentioned celiac disease in their profile, and only one reported using a celiac disease specific dating platform. About 5% bring their own food to a date. Most, 69%, feel comfortable explaining to waiters about a gluten-free diet. Celiac disease causes 30% of the participants to be hesitant to kiss. 2% eat gluten on dates, and 21 participants, or 14%, reported risky behavior on a date. And then some, about 6%, were hesitant about physical intimacy due to symptoms of the disease, and about 4% think that their partners must follow a gluten-free diet. And also, interestingly, they looked at the differences between the subgroups' experiences, looking at the calculated impact of dating, and found that there was a significant difference with time being on the gluten-free diet. So they looked at up to 1 year and then over 10 years of following or maintaining a gluten-free diet, and found that the longer that you were on a gluten-free diet, the less of a difference there was on that impact. But early on, after diagnosis, there was major or moderate impact calculated for dating. And so they concluded that enhancing awareness and understanding celiac disease in the broader community could mitigate behaviors and anxiety related to dating, and also improved awareness could promote a more accepting and inclusive and supporting environment. The next abstract that I'd like to present was done by Yvonne Jeans and her team from the University of Roehampton in London, and their study aim was to evaluate the impact of a dietitian-led pre-recorded webinar for adults with newly diagnosed celiac disease. And data presented was collected from 2022 to 2024 using pre- and 4-week post-webinar with an online questionnaire. And that included gluten-free knowledge questions modified from Sylvester et al., as well as questions on confidence in adhering to a gluten-free diet, and also behavior questions. And online surveys as well as paper questionnaires were sent to all the patients. And the results indicated that 138 adults completed both the pre- and the 4-week post questionnaire after the webinar. Adults with celiac disease reported that they were significantly more likely to either always or often avoid cross contact within the home following the webinar, and they were significantly more likely to either always or often ask others questions who are preparing food out of the home, and the gluten-free dietary knowledge scores significantly improved post the webinar. And lastly, I'd like to present an abstract that was done by Dr. Inez Pinto Sanchez and her team from McMaster University. And this was on the topic of overnutrition in treated celiac disease patients, the need for personalized nutritional assessment to manage metabolic sequelae of gluten-free diet. And just background information that was given indicated that there is an increasing frequency of overweight and obesity reported in patients with celiac disease, which may be related to the characteristics of a gluten-free diet, including foods which are higher in sugar and fat and are more ultra-processed. And this could lead to increased risk of developing metabolic syndrome and also MASLD. And factors contributing to this metabolic shift in treated celiac disease patients have not really yet been well defined. And so their objectives were to assess differences in energy needs, evaluate factors associated with increased weight, and assess frequency of MASLD in celiac disease and non-celiac disease populations. And so adult patients with biopsy-proven celiac disease and non-celiac disease patients with GI conditions such as either IBD or IBS, in whom celiac disease was ruled out, were recruited from the nutrition assessment clinic at McMaster, and MASLD was diagnosed if hepatic fat content was greater than 5% with the presence of at least one of the metabolic syndrome criteria. And the results indicated that there was a higher rate of overweight and obesity in the celiac disease patients. So there was 73% total of overweight plus obesity in those patients versus 48% in the non-celiac disease group. And also they found that MASLD was more frequent in the patients with celiac disease as compared to the non-celiac disease group. So 81% compared to 43%. Energy expenditure was also looked at, and this was weight adjusted REE. This was also found to be lower in the celiac disease patients in comparison to patients with other GI conditions. And so they concluded that a personalized nutrition assessment and accurate measurements may allow for targeted interventions to improve health in patients with celiac disease. And I'm just going to pass it on now to Catherine, and I'll stop sharing. All right.
But if someone has some comments about the dietitian abstracts, please feel free to either comment on the chat or raise your voice.
I have a question for the last abstract that you presented in terms of the BMI and looking at MASLD and so on. How long after diagnosis were these patients actually looked at, and did it matter the amount of time that the child or the adult was on the gluten-free diet? And were there more assessments in terms of the kind of diet, it was more processed foods or not, or is it something inherently with the celiac population?
So these were all adult patients, first off, and the time was not included in the abstract for that question.
The author is on here, so maybe Dr. Pinto Sanchez can unmute and tell us something.
Yes, I'm here.
Yes, I tracked you.
So there was an average of, all of them were more than 1 year gluten-free, and there was an average of 7 years of diagnosis. So these are people with well known and familiar with gluten-free. And the majority of, we are doing a deep analysis now on NOVA for the ultra-processed food to look into in depth the processed food of these patients. We do have all the data and the questionnaires and the 24 essays that we analyze. And the majority of these patients were consumed high amount of ultra-processed food.
So did it matter how long they'd been on the diet, or?
Yes, we didn't see any difference we compare with the analysis, and we didn't see any differences in terms, any big impact on the length of the diet. And but the majority of them were after 2 years. Very few were within 1 year or two. So so we don't have anyone, and we don't have any comparison before and after. We will be, it would be nice to have that. So this is a prospective data collection that we are doing. So
thank you.
no problem.
Right, so if there are more questions, we can field those towards the end as well, but I will carry on into pediatric abstracts. And I picked a few here to share with you guys today. So the first one is from the group out of Children's National, Jack Vagadori and Dr. Coburn, looking at the feasibility and acceptability of at-home gluten immunogenic peptide testing for adolescents. So as we know, there's no empirically supported behavioral interventions to date for children with celiac disease and their parents, and really no gold standard for monitoring adherence to the gluten-free diet. So GIP testing is a promising technology for detecting gluten ingestion but we don't have any significant clinical recommendations or support for these. So the GROW project is a 6-week telehealth-based group intervention where they have teen and caregiver dyads. And the goal is to optimize self-management and quality of life. So their objective was to test an enhanced version of the GROW project, integrating an at-home GIP testing. So they recruited teens between the ages of 12 and 16 with physician-confirmed celiac disease diagnosis and their parents. There were 5 groups that participated in the GROW project. They had 3 GIP kits distributed per week, and they really wanted them to do at least 2 of those tests during the week. The kits included collection cups and gloves. They got education, counseling, and support during these sessions. And they were also to keep track of their weekly symptoms and exposure and test reporting. And then there was discussion of the testing experience during sessions and post-intervention interviews. So the average age was 13, and you can see the rest of the demographics there, with the majority of the participants being female and non-Hispanic. So the weekly report and post-intervention interview completion was high. 70% completed the weekly report. The average total completion of the tests was 8.6, and average weekly completion was 1.4. And you can see some comments from parents and teens in there. So one of the parents helped her daughter the first time. She didn't want her to be in the bathroom. It was a lot of work to convince her. But she ended up accepting help because she couldn't figure out how to use it. And one of the teens commented that they thought it was really helpful. They went on a trip and was scared to see how the test would come out. It was negative, and they were glad about all the precautions that they had taken on their trip. So out of all the testing that was done, all of them were negative in the enhanced intervention group. So with the post-intervention interviews, one participant reported feeling some stress or anxiety before taking the test. They felt disgusted by it, but 3 out of the 5 participants reported feeling no concerns prior to taking the test. They felt some relief and reassurance from having those negative results, and it increased their confidence in their gluten-free diet management following the testing. And 3 out of 5 of the parents reported assuming most of the responsibility of the testing for their teen. So their conclusions were that these types of tests in adolescence is feasible, and guidance around taking the test may improve research protocols and clinical care. And looking forward, having larger groups of patients and more diverse sample and subsequent cohorts will be helpful. Moving on to the next one, this is from Dr. O'Shea and Dr. Green's group, looking at provider attitudes towards non-dietary therapy in pediatric celiac disease. So looking at patients and caregivers, we know that there's interest in non-dietary therapy for the treatment of celiac disease. So their aim was to really look at providers' perspectives by assessing their knowledge about potential new non-dietary therapies for celiac and their perceived need in the face of a safe and effective dietary therapy. So this was an online survey. There were 103 pediatric gastroenterologists, and most of the medical providers were concentrated in an academic practice setting, and had a higher percentage of pediatric patients than nutrition providers. And there were 40 dietitians and nutritionists, and they looked at their knowledge and attitudes about non-dietary therapy as an adjunct to the gluten-free diet and as a replacement for the gluten-free diet. So of this group, 32% were part of a dedicated celiac disease center, and 51% had a personal connection to celiac disease. So they either have celiac disease themselves or knew someone with it. 89% of all respondents were aware that there are medications under investigation, but 23% were not at all familiar with them. Medical providers were more familiar with the non-dietary therapies than nutrition providers. So the following factors significantly increase the perceived need for this. So being a nutrition provider, working at a dedicated celiac center, or having more years in practice, in addition to having more knowledge about celiac disease and the gluten-free diet. No factor significantly impacted the perceived need for replacement, non-dietary therapy. So looking at the factors that are determining the likelihood to recommend or prescribe non-dietary therapy for a pediatric patient. So on a scale of 0 to 5, 5 being the most important for these people who were surveyed was the safety profile. Next was ability to improve quality of life. Less important was the patient's age and patient's current celiac disease control. So more respondents felt that non-dietary therapy was needed as an adjunct rather than a replacement. And none of the following factors were statistically significant. So practice setting, pediatric patients in the practice, the average number of celiac patients per week, the personal connection to celiac disease, and the awareness that non-dietary therapies are in development. All right. So I will pause there and see if anybody has any questions about these two studies. And I think we've got some of the authors of the studies in the group here. And if we don't have any questions at the moment, we will pass things along to Drew.
Thank you, Catherine. Let's get things shared here.
Can you brush your teeth? Did you brush your teeth? No.
Oh, here. On screen. All right.
We see your presenter view and not full slide.
I know. Oh, goodness. Forgive me. All right. There we go. Okay, so I'm Drew Ford. I'm presenting this really interesting study that came across ICDS and actually is now published in Journal of Pathology and Informatics. This came from Dr. Sylvester's group, as well as Jeffrey Law. This is a VICE, which is a software. It's an automated and quantitative program to assess intestinal tissue morphology. So, of course, the villi and crypts are crucial for all components of digestion and absorption, and they're obviously implicated in celiac disease pathophysiology. And one of the ways that we can assess them pathologically speaking is looking at the villus crypt morphology, because at the end of the day, the morphology impacts that absorption. When we look at the villus height and crypt depth ratio, that's one of the better objective measures that we have to determine whether or not celiac disease might be present. And right now, in the pathologic assessment, there are two branching points you can go in terms of assessment, which include the descriptive scoring systems like the Marsh criteria, for instance, and then you can also manually measure the villus height and the crypt depth to calculate that ratio. So the thing is that the qualitative methods have very poor inter-observer variability, and the fact of the matter is with these with manual methods, while those do have better inter-observer ratings, the fact of the matter is that they're extremely manual and tedious. So with large sets of pathology slides, spending quite a bit of time doing it. So it begs the question: what is a better way to automate and expedite this process and enter VICE and other automated ways to assess? Excuse me. And frankly, these limitations to be overcome by an automated process. So VICE is a software developed to address just those things. It addresses tissue quality and orientation, and it generates these quantitative measures, specifically the villus height crypt depth ratio, though it can produce many other objective measures too. It interestingly identified possible pairs of the villi and crypts as lollipops, which are then analyzed for whether or not they are good fits, okay fits, or poor fits based on the imaging features. And specifically the good quality pairs, which are strong enough, those are what are used to generate the program's version of the villus height crypt depth ratio. So this is an interesting picture from the recently published study that shows how the program works. Specifically, I'll point out that you can see those little lollipops that are green, which is the good category, then red is the poor one, and then yellow is the okay. And remember that the green ones are the ones that are being used off the bat. So the question then that this abstract sought to answer is, how does it compare to the established methods, such as manual crypt depth, villus crypt depth ratio calculation? So they took VICE and validated across a combination of internal samples as well as publicly available images from histology atlases, which was great because these are very diverse in their resolution and their staining. And at the same time, the mathematical models that are employed by the software are agnostic to these aspects. So as long as the decent enough image, it will actually be able to obtain the information that we need. So the outputs of the software were compared against manual measurements from the validation images. And then measurements of the villus height crypt depth ratio on those validation images were done by two authors blinded to the software outputs. Identification rates compared to the manual measurements was calculated, as well as the false positive rates. So then, as far as the results go, 69% of the villus crypt pairs were identified when compared to the gold standard, and the false positive rate at the same time was less than 10%. The correlation you'll see is very strong between VICE and manual calculation. While interestingly enough, the crypt depth was underestimated a bit in a fraction of the patients. Importantly, though, the villus height was correct almost always with 0.88 in the correlation. And at the end of the day, VICE provides us what looks like an efficient means of quantitative villus crypt morphology assessments. This strong correlation, it helps us move things along. And even if you want to have somebody manually review at the end of the day, if you think back to the way that it abstracts the good, okay, and poor pairs, it can target good pairs for the pathologist to focus on, therefore cutting down time used to manually review the slides. And there are additional features too in the program that, with more assessment and analysis, I think could provide even deeper and more expanded ways to analyze celiac samples in the future. But a fantastic study, and looking forward to seeing what else comes out with it. And with that, I will turn the floor over to anybody who might have any questions.
I have a question, but maybe it's for Jocelyn, who is on the call also. Was the software able to say whether or not the biopsy was misoriented?
Yes, that's actually one of the great uses of it, is because the scoring of the quality is a proxy for orientation. It's very good at screening for oriented biopsies.
So Jocelyn, how much time does it take to do this sort of assessment? When you think about a video capsule, you think about hours and hours of looking at a lot of screen. What's the time factor here?
We run it on just a standard laptop, and from taking the image in to giving you the data is 30 seconds.
Wow. And do you see this as a help in the potential celiac patients?
In terms of being able to better quantify their villi?
Yeah, and to see maybe a little bit further down.
Yeah, I think that's probably definitely one of the applications. We also have applications where we can combine it with fluoroscopy so that we can look at multiplex immunofluorescence as well.
Very interesting.
All right. So for the last part of this webinar, I'm going to touch upon the refractory celiac disease topics, especially one abstract that I found was very significant for our practice with refractory celiac disease type 1. One abstract about PET-CT in RCD2 and EDOL, some talk we had about tofacitinib and refractory celiac, and other highlights that I got from the session about RCD. So I'm just going to move this. All right. So we usually consider like RCD1 as something benign compared to RCD2. RCD1 is defined as being like having cell villus atrophy, having some symptoms, but not having a risk of having necessarily a lymphoma. There's no like aberrant T cells. And recent studies from the Sheffield group showed that it could be also missed gluten exposures. They did urine GIP in some patients with RCD1. And the Europeans in their guidelines also have the concept of like slow responders. So some people that are still having some villus atrophy down the line after 1-2 years, could it just be because we did not give them enough time to heal? While RCD2 is considered as something like a lymphoma in situ with lots of aberrant T cells that are clones. The treatment is challenging, and over the last few years, several like mutations in the JAK-STAT axis have been discovered that could that are kind of like implicated in RCD2 and the lymphomatogenesis of that condition. But the work presented by Manu Singh from Australia is showing very novel, thought-provoking data about RCD1. It's a more extensive work than what I will show, and you can refer to their preprint that was published this year. In this study, RCD1 was diagnosed after not seeing any aberrant T cells and excluding other enteropathy. They included 10 cases. 2 had still abnormalities in their immunophenotyping that were not considered RCD2, but 1 still got a treatment with cladribine because of their abnormal flow cytometry. So they used several single cells analysis and multi-omics techniques, but the main one was single cell DNA sequencing, targeting some somatic mutations that were frequently implicated in RCD2 and EDOL. And they did those analysis on duodenal biopsies. And they found some clonal T cell expansion and some somatic mutations associated with lymphoma. It's in 7 out of 10 of these patients. The main mutation involved were STAT3, STAT5B, DDX3X. And looking at the T cell receptors, they also found several clones, but those clones were mostly like surface CD3 positive and CD4, CD8 negative. It's a finding that we have sometimes on our flow cytometry data that I assume were regular like gamma delta T cells. And the patient treated with cladribine did not have any changes in the clone and the mutation before and after the treatment with cladribine. So they concluded that overall their results highlight the power of single cells multi-omics in identifying and characterizing rare pathogenic lymphocytes in refractory celiac disease, and provides evidence for a shared pathogenesis of autoimmunity and lymphoid malignancy. But it brings us like lots of additional questions about like what is the enteropathy that we say, oh, it's RCD1 in some of our patients. It may not be as benign as we thought. Their patients, from my knowledge, did not develop lymphoma, but they had those mutations that could down the line become a lymphoma. However, Georgia Malamud in a subsequent talk about RCD was saying about how like RCD1 could be in fact like having a few somatic driver mutations that are kind of like having a selective amplification in the inflamed tissue of T cells that has acquired mutation through clonal hematopoiesis, while RCD2 is to have like several somatic drivers mutations and abnormal like IELs that clearly have aberrant T cell receptors. Looking at the mutations that they found, the gain of function mutations, there are other diagnoses that could overlap with celiac disease, like large granular lymphocytic leukemia. Autoimmune enteropathy has also been shown to have those STAT mutations, and also chronic indolent lymphoproliferative disorder. So these are all like other conditions that are not as benign that could be seen in that patient population and have some mutation. But it also highlights how like we may need a better diagnostic algorithm for these cases, because I think we have on one end like some overall relatively like benign case that we'd say, oh, they have refractory celiac disease because they're still having symptoms, still having atrophy despite being on a gluten-free diet, but they are not having like severe malnutrition, and they may have had intermittent like gluten exposures in fact. And on the other end, we have those cases that have actual somatic mutations. And unfortunately, in our US centers, we are not having an easy access to those mutation testing in the tissue, and clearly not approved by insurance. So this is something to think about in some of our patients with like refractory like enteropathy that doesn't fit with the diagnostic criteria of RCD2. They may still have some mutations. The second abstract I would like to highlight is from the French group, who has extensive refractory celiac disease experience through their Celiac network. So they look at their RCD2 case and EDOL who had a PET-CT, and found that all the RCD2 patients did not have any like abnormal findings on the PET-CT results, compared to the EDOL group, that overall 26 patients had positive PET-CT showing like captation, and 4 had negative findings. So they concluded that the sensitivity of the PET-CT to diagnose a lymphoma in RCD2 was 86%. The specificity was 100%, negative predictive value 91%, and the positive predictive value was 100%. So to do a PET scan in our patients with refractory celiac, that we are unsure, like, are they like developing an EDOL, could be a reliable tool to rule out the EDOL. However, when we have a higher clinical suspicion and a normal PET-CT, we should still proceed with like capsule endoscopy, enteroscopy, or laparoscopy. Gerd Bouma from Amsterdam presented their data about the use of tofacitinib in refractory celiac disease. That was a poster in 2022 at the prior ICDS meeting, and it has been published this year in Clinical Gastrohepatology. So they had 6 cases with type 2 refractory celiac disease, 4 from Amsterdam, 2 in Germany, who tried several medications for their RCD2 without success, and they were put on tofacitinib 10 milligrams twice daily. And all patients had rapid improvement in their weight, reduction of their diarrhea. Some that were on TPN were weaned off TPN. They also all showed improvement of their villus atrophy, although 2 still had villus atrophy on their follow-up endoscopy, but 4 of them had like no more villus atrophy, which is really great. And after 12 weeks, the one who stopped had the clinical recurrence, and they resume it at 5 milligrams twice daily with good response. So they have follow-up data for like 2 years, and these patients are still in clinical remission. The main side effects were having transient lymphopenia. There was 1 line infection, 1 pulmonary embolism. Just a reminder that RCD2 is a highly inflammatory state. It's like to have active IBD, and it's not uncommon that these patients develop like deep vein thrombosis and pulmonary embolism. 2 patients had possible bacterial translocation, but I think that it may more be due to the RCD, ulcerative ginginitis, and not the tofacitinib. And as part of the effect of the JAK inhibitors on the T cells. One possible mechanism that was supported by their immunohistochemistry data was the inhibition of granzyme B expression, which is one of the mechanisms by which the IELs kills the enterocytes. However, the aberrant T cells did not disappear in the 6 patients treated with tofa. They have no EDOL observed in the 2 years follow-up. One patient still got an autologous stem cell transplant, considering the persisting villus atrophy. So it looks like the T cells are still there, but they are less like cytotoxic. The mucosa is healing, and the symptoms are clearly improving on those JAK inhibitors. And a few other things I would like to highlight. Christophe Celiac in his talk mentioned some therapies used so far. Budesonide is widely used, but EDOL can still happen. And he suggested to consider a stem cell transplant earlier if there is persisting villus atrophy after a budesonide course of treatment. The French group did not report any lymphoma post autologous stem cell transplant, but the Netherlands group had at least one case with EDOL post autologous stem cell transplant. And Dr. Celiac also mentioned the 5 years follow-up of the 11 patients who were enrolled in the IL-15 trial with Amgen 714. 2 out of 3 in the placebo group had a celiac disease-related cancer, so 1 lymphoma, 1 adenocarcinoma. The 8 patients in the group that received the treatment are doing well, except for 1 who had a lymphoma. 5 do not have villus atrophy anymore. 2 are now polyclonal, so they lost their TCR clonality. 1 received budesonide, and 1 had an autologous stem cell transplant, but the others are on a gluten-free diet only. And like for tofacitinib, the drug did not have a strong effect to remove the aberrant T cells, but they also seem less cytotoxic because there's less like mucosal injury, and the patient are overall like not so symptomatic. So far, all of our treatments for refractory celiac disease type 2, like tofacitinib, stem cell transplant, and the anti-IL-15, doesn't seem to make the aberrant T cell disappear, but it can have an effect on their cytotoxicity, on their function. And finally, I just want to emphasize a point from Joe Murray about budesonide. This is not his slide. I made the slide inspired by his talk and his slide. So we keep saying that budesonide compared to steroid is a topical steroid that has a high first-pass elimination by the liver. So there are few steroid-associated side effects. However, we still have patients stopping their medication because of side effects. And it's important to keep in mind that the medication is going through the CYP3A4 pathway for the deactivation of the budesonide in the liver. And if the patient is on some medications that are inhibitors of that CYP or natural products, or even like turmeric, Joe Murray mentioned that one of the patients was on that natural like supplement that reduce the inactivation of the budesonide, and the patient can have more like systemic side effects. So something to keep in mind in your counseling, and also if you see some of your patients getting like side effects with budesonide. So that was what I had about the refractory celiac disease topic. So, but I have a comment about one of Sharon's like abstract about the toaster and the cooking and everything. Like it was published, I think, like 5 years ago. Also, like some kind of like preliminary data about like the toasters and everything. And what are you doing for your counseling with your patients?
So I think that I recommend just using personal judgment too. I explained that the study was done with the toasters, but in your own household, if you see breadcrumbs all over your toaster, then that might mean that you use your own judgment and either clean your toaster before you put the bread in there that's gluten-free, or decide to have a designated toaster. But I think that the main point of these studies was that washing was adequate. for the other things, right? So, but same thing with the toaster. If you've got a lot of busy people in the household that are making a lot of crumbs all over the toaster with gluten-containing bread, then that might be a different story than using a toaster that is relatively not covered with crumbs that you put the gluten-free bread in.
And Sharon, just to add to that, this is Kate. I'm also one of the authors on the study. We also wish to clarify in a hopefully forthcoming manuscript that this is only for home use. We are not even close to recommending this for any type of use, like at a restaurant, at a hotel, anywhere like that.
Thanks, Kate.
All right. So if no one has other discussion point, we can proceed with the closing. So we will have other webinars. The Nutritional Assessment Project, Anne-Lee will give us an update from the international work group. So that Nutritional Assessment project was recently accepted for publication in the American, the Journal of Dietetics. So that was a kind of an American project that we did. And now Anne has expanded to an international work group that met at ICDS this year in Sheffield. And she's gonna provide us some updates about that. And we want to explore also the new apps and technologies in celiac disease. So this is also to come. And most webinars are recorded and posted on the SSCD website for member. The SSCD website was recently revamped, thanks to Downs Adams teamwork. And yes, you can keep up with our news and updates through that website. So thank you very much for all the SSCD committee member, the audience, the presenters, and the SSCD Council for helping us keeping this webinar afloat. So I wish you all have a nice evening.
Thank you.